It's great to see so many of you on a Wednesday coming towards the end of the conference, and I hope you feel it's been a great conference, yeah? I really feel that was a powerful presentation, giving recognition to people who are changing the world. But sometimes we've got to go a little deeper. We're going to hear some stories now from a user panel who are well qualified to give us that viewpoint from an early stage to middle stage of startups as they grow their business. So please welcome to the stage Kenzie Butera-Davis, Maro, CEO and founder. Ellender, CEO and co-founder of eConsult, you just heard him mentioned. Thank you. And Daffas, CEO and Managing Director of PainChek. So all healthcare, but their stories are relevant to anybody trying to bring innovation to the world, to get that innovation into use. So what we're going to do is going to ask them what the company does, what they do, how they got there, and their lessons along the way, and then end with a future note. So I'm going to start with Philip. Philip, tell us a bit about PainChek and the innovation they bring to the market.
Well, thank you, Mike. Before I talk about PainChek itself, let me just explain the problem we're addressing. Pain assessment is very difficult, but it's especially so for very extreme cases, including people living with dementia and cognitive impairment at one end of the scale, who've lost their ability to reliably verbalize their pain, and on the other extreme, pre-verbal children who have not built those communication skills up as yet. So what we have developed with PainChek is a technology to help those people. Our mission, our vision, our goal is to give a voice for those people who cannot reliably verbalize their pain. There have been paper-based pain scales available for many years, most of them generated by the American Geriatric Society in response to the non-communicative skills of those people. But those paper-based pain tools are rarely used. They're subjective, they're difficult to use, they're open to bias, and therefore rarely used. And what that means is that people with dementia, pre-verbal children, it's all guesswork in terms of their pain. We have developed two products, the PainChek adult product and the PainChek infant product. And what we do, they are both mobile devices. They work on your phone or any edge device. They're regulatory cleared in multiple markets, and we're working on the FDA now. And they use artificial intelligence to do the most difficult part of the pain assessment. We run a 3-second scan of a person's face and pick up the microfacial expressions of pain and document it for the carer. We then guide the carer through the remaining parts of the process, and the result is a pain score of no pain, mild pain, moderate or severe. And from there, you can actually treat the patient with the right, correct medication.
Thank you, Philip. And you know, this is very complex, so giving a voice to people who can't vocalize their pain, doing it consistently using AI on the images, really useful. I know I've loved ones who would make use of that, and we'll come back to you. Mary, tell me what eConsult do for the world.
Sure, thanks, Mike. So I'm a GP by background, or a family practitioner if we're in America. And I've been a GP for nearly 20 years now, and we grew a physical health business. So we ran a number of NHS GP surgeries.
So this is primary care?
Primary care in the NHS, and we had about 15 sites. But we realized that actually we would, like every other supplier, drowning under demand, a weight of demand, too many patients, couldn't get appointments. And patients would be queuing on the phone at 8 o'clock in the morning in order to try and book an appointment. We'd then tell them to ring back the next day because there were no appointments left. And then eventually when they get through, you bring them into a building 2 weeks later to be seen. And that was the kind of, 10 years ago, that was the model of family practice or general practice. And we thought, actually, there must be a better way to do this that's better for patients and more efficient for us as doctors. And so we came up with this idea of, look, if we could gather the story from the patient before they come in, so while they're at home, find out what's wrong with them, put that in front of the doctor, they can actually then make a decision and often treat that patient without bringing them into the building. So we built this really, version 1, we picked 50 common presentations into the general practice and wrote all the clinical content, so what would I ask that patient as a GP, and put that on our website and pointed patients at it. And it worked. And we soon found that actually a lot of cases you could manage without bringing the patient into the building, which is great for the patient and more efficient for the practice. So this was 10 years ago now. So we've taken that idea and now taken it outside of our own practice. It's now in 2,700 GP practices in the UK, serving about 25 million patients. And over the last 10 years, we've done 38 million online consultations. So the product has evolved and improved. And the next stage now is we've taken that same idea and applied it in a hospital setting. So
okay, we'll come back to that. Let's hear from Kenzie. Kenzie, tell us a little bit about what you're doing to change the world.
So we are the early stage company on the panel. We're the startup, and I think we're solving one of the most interesting challenges in pediatrics, which is the early identification at the time of onset of mental illness and behavioral health concerns. So according to the Children's Hospital Association, which is 220 children's hospitals in this nation, there's an 11-year gap on average between the first time a child shows a symptom that they could be struggling with their mental health to the first time that that child receives any form of treatment or intervention. That's a huge problem. And so what we do is we partner and really sit at the intersection of schools, families, and providers to make sure that there's appropriate screening implemented at all age levels, that we're identifying things early, we're including the family for proper consents and release of information, and we're connecting them with providers or other tiered interventions at the right time.
Thank you. That's very, very interesting, and definitely needed. There are so many vulnerable people in the world. When they get a good start in life, then they go on to be great, productive people. When they don't get the start they need, well, we have a need to look after them, and you're providing that. That's terrific. But what gave you the insight to start that? Why are you doing what you're doing?
I started Maro after it was really a combination of both personal and professional experience. So I thought I wanted to spend my career working in nonprofit direct services.
Okay.
I was specifically working with survivors of domestic violence and rape crisis. It's an issue that has personally affected me and my family and is really near and dear to my heart. And it led to this whole journey of kind of, why are these kids and these families kind of ending up in these situations in the first place?
Yeah.
Could we have used health education, for example, to prevent this? And the data really backs that, and I won't go too far into that. But I ended up spending this sort of career journey in the startup space that had nothing to do with nonprofits. I loved it. I worked in venture after that. And I applied my professional, expertise that I had gained to a problem that I care really deeply about. And health education is very broad, and I decided to really focus my efforts specifically on the mental health side of that. And then I brought in a fantastic clinical team and data science team and technologist to help me, achieve what was sort of an emerging vision at the time.
Because you can't change the world alone, so you brought the team in. Yeah.
Couldn't imagine doing it alone.
Thank you. Murray, tell us, why are you doing what you're doing? What makes eConsult get you out of bed and go to work each day?
Well, we're doing it mainly because the healthcare, and we're focused on the UK at the moment, but healthcare across the world is faced with the same problems, which is increasing elderly population, more complex disease, and actually a health system that can't cope. So there's a real challenge trying to match the thin workforce to the right patient. And actually, so for us, kind of digital triage offers that opportunity to make sure that we're using our health professionals at the top of their license. So making sure that the right patient ends up with the right clinician first time and every time. So that, for me, is kind of what this is all about. We started out in general practice, but actually are now applying the same concept in hospitals. And actually, if you gather information about a patient up front in a very structured way, it helps you identify who's the best clinician to deal with that patient. So and I just want to do that, change as many healthcare journeys as I can in that way. So that's what's driving me.
So changing that quality of experience for both the patient and also for the giver, get that right care, right time, right place, right in all those ways.
Exactly.
Philip, what led you to
Mike,
take this innovation to the world?
I've been in the diagnostics, medical diagnostics and devices field for almost 40 years now, so I'm not quite as old as InterSystems, but I'm working at it. Look, I've been very fortunate to work with some very innovative companies, including Roche Diagnostics and Boehringer Mannheim, where we were involved in launching and developing the blood glucose monitors that are now used at home every day by people with diabetes to care for their diabetes. That was a novel breakthrough we made when I was working in Germany with that company. And I also, when my move to Australia, came when I worked for a company called Cochlear, who were the leaders in the multi-channel cochlear implant development to help people, deaf people who lost their hearing to rehear, and for young children when they're deaf to actually have a cochlear implant and live a full life. And in fact, my youngest daughter was born deaf while I was working at Cochlear.
Okay.
And she's implanted, and pleased to say she's married now and living a very happy life. So I've always loved the idea of this, how to help people, how to make technology improve people's lives, and seeing the PainChek opportunity, it was 7 years ago, and I thought, this has got all the ingredients of being able to take an Australian technology and take it global, and that's what we're in the process of doing now.
So personal experience really is a driver on how you want to change the world.
Absolutely.
That's great. So as you build your business, as you are, how do you make sure that people understand what you've got? How do you confront the unbelievers, both outside and inside the organization?
That's me again.
Yeah.
Look, that's a really good point. And I think one thing that's really, with the experience I've had is that we built the PainChek technology based upon the old gold standards. Yeah?
Right.
So we didn't try to change the way people work. We didn't change the clinical practice. We improved the clinical process. And therefore, we brought the people that were using the old technologies and it wasn't working very well along with us, and those people that actually developed them, like a lady called Dr. Jennifer Abbey, who had the old pain scales used in the UK, used in Australia and various places. She's our biggest supporter. So when people call her and say, this PainChek product, does it really work? Is it the right technology? She's supportive. So bringing people along with you from the past is really important to get yourself embedded into the future.
So you said a key phrase there. Don't try and change the process, improve it. Because you're meeting people where they are.
Absolutely, because then you actually you don't say to them, I'm changing everything you've done in the past is no good. You're actually saying, we know what you've got, we know it's difficult. And the example I gave, in fact, early in my career, I worked for a company called IVAC. We made the first ever electronic thermometers. We took the concept of how a glass mercury worked, and we developed an electronic version. It was the first one in the late 70s. And again, that was, improving the process without changing the clinical practice.
Okay, improve the process, don't change the practice. Now, sometimes people are going to change the practice. Maro, you're changing things. And you had an innovation that worked within the practices, and you got 38 million consultations, so you've built that. But you still need to bring that change of thought and process to a market. How do you go about that?
Yeah, I think it's been a theme actually throughout the last 3 days. You've got to bring your team, the clinicians with you, so your customers with you on that journey. And that was, I think, one of the core things for us when we were considering how do we get GPs to adopt this technology, because actually patients tended to adopt it very easily. They were craving an online way to interact with a doctor. But for clinicians, the challenge really is they're very busy. And actually when you present a solution to someone who's really busy, the first reaction is, that sounds really interesting, but come back next week because I'm really busy. So you've almost got to, you've got to go with them. You've got to prove those examples. I think the thing we did was we had a kind of exemplar. We had a laboratory. So we had this test bed of practices. We proved that it worked. And then it grew organically from there. We were able to show, actually, look, this does work. There's often kind of quite a lot of geography. So you go down to Devon in the southwest of England and say, I'm sure this newfangled technology works in London, it won't work down here. So you have to set up a kind of exemplar in that place. But actually, it spreads by diffusion. So I think, that's, we're quite well penetrated across general practice, but the next thing for us is to take that into hospitals.
Okay, we'll come back to that hospital when we get to the future part of the discussion.
Of course.
Kenzie, you're dealing with institutions, you're dealing with people who know what they're doing in their job. How do you get the permission to bring the change that you're bringing, that you know will help them? How do you convince them? How are you going about that?
I think what Maro has going for us right now that I couldn't even say, a few years ago, 2017, 2018, is we really have product zeitgeist fit. There's this movement toward mental and behavioral health supports because we've gotten so far onto the side of schools where we're screening and health systems where ultimately we're heading, feeling incredibly overwhelmed and incredibly overburdened and really just sort of desperate for solutions that can start earlier than teletherapy and telepsychiatry and some of the other amazing, wonderful things that have come up in the past decade. And so I think, some of the key market drivers for us are policy. We're starting to see actually at the state level legislation that is being proposed. It's in committee. I imagine that many of these proposals will pass here in the next legislative session, some of which would mandate universal mental health screening in K-12 schools. And so these districts are going to be looking for compliant solutions that can help them get there, and that's exactly what Maro offers. The other thing is there is, pushes for mental health curriculum, and I think, we're early enough that we can say we don't necessarily have to convince the people who don't believe in the problem or believe in the solution, because we're going after our early adopters still who are very enthusiastic about our product. But we run into these objections all the time. Mental health doesn't belong in school, and I think, what we're trying to do is tie school performance KPIs and kids' future economic potential and success to the impact of mental health and just showcase opportunities where we can actually save a lot of time down the road and a lot of money because of our services.
You're right. So you're at a point where mental health now, people understand it needs the transparency and parity with physical health.
Right.
And in fact, it isn't something separate. It's actually part of the physical health journey.
Exactly.
It's not separate. So going on to Murray then. Murray, you had this innovation within primary care. You talked about hospitals just then. Tell us a little bit about how you're bringing that up, but stay with the point that was just discussed. How do you get to the policymakers? How do you get the institutional change? So let's still talk about bringing change. If you could speak to that, please.
Yeah, I think particularly when you're kind of introducing a new innovation, that's a real difficulty, because you've got to, you can go into a hospital and we'd start with the kind of A&E consultants and they'd be brought in, but you've then got to go through all the layers of bureaucracy in a hospital in order to convince someone at the top to fund it, and then it's got to go to IT and estates, and so there's lots of people to convince, and that's just to get your first kind of test bed off the ground.
Yeah.
It clearly helps having done digital triage in another setting, but what's key is to find that kind of that innovator hospital or provider to work with you on that kind of use case, proof of concept. And that's what we did moving from general practice into hospitals about 4 years ago now. And we found a provider. It was actually an urgent care center, which I always describe as a bit like an emergency department without ambulances. So it's kind of people walking in with illness and injuries. And they, in the local GP practices, were using our primary care solution. So actually it wasn't a great leap to apply that in that urgent care setting. So, but it took some bravery. We then took the whole team out for 2 days, out of the setting, and said, look, this is how your process works today. Walk in, book in with a receptionist, see triage nurse. What if you could start again with a blank sheet of paper, how would you do it? And we got the team and our clinical team and our engineers all in the room for 2 days and redesigned that process. And that then was what was implemented. So yeah, but
To see the problem from the user's point of view.
yeah, really
Okay.
important.
Thank you. Philip, now, still talking about policymakers, and you're in the kind of middle stage of your business. How are you dealing with policymakers? And I think we can talk a little bit about regulation, because obviously you've got a technical process there of charting someone's pain points on their face. What countries and how different is that regulation process been for you?
Good question. Well, we took the technology out of the university. It was a PhD project at Kirk University in 2016. We took it out of the university. We actually formed the company at the end of 2016. We finished all the clinical validation work, 4 peer-reviewed publications to show accuracy, sensitivity, specificity, and inter-rater reliability, which was critical for the regulatory clearances. We got TGA clearance in Australia, CMARC Europe, MHRA for the UK, and also Canadian Health. We're actually in the process of now doing de novo for the United States markets for FDA. And so with those 4 clearances, we started in Australia. We now have something like 22% of the long-term care facilities in Australia using our technology. That's about 60,000 beds in long-term care. We're in New Zealand as well now. We've got about 20,000 beds covered now in the UK. And just this week, my colleague, and last week, my colleague, we started our first 2 Canadian sites. So overall, it's been a fantastic journey. It's been, we're a small company, 25 people. So it's a lot of work, but we've done a great job. And we've done actually 2.7 million clinical pain assessments in that time. Wow. So it's probably the largest clinical pain database in the world. So we're down that route, and as I say, the biggest one now for us is FDA de novo. We're right in the middle of the clinical study, and that will be looking at American populations. And the real issue is that the human face, we do the facial assessment, but the human face, it's a global face. We all use the same muscle movements, or called action units, on our face to express our features and our emotions. So happiness, sadness, anger, we all around the world use the same muscle movements to do that. That was done by Professor Ekman a number of years ago. So what we have done is we identified the 9 muscle movements that are activated when you're in pain, and we actually scan the face. We don't store any photographs, we just scan the face, and then we pick up which of those are present at the time. Some of those are not visible to the human eye, and that's why you can't do this with humans. And then we document it for the carer. So it's safe. It covers all privacy issues, and it gives information that's really valuable to the nurse. And the great thing about it actually is that in the past, only specialist nurses, registered nurses, could do pain assessment. But because the tool is so automated and simple to use, actually this is where the real innovation is. Anybody can use it. And so therefore, right now it's in professional usage, but long term we see for adults, for family members at home to look after their family members with dementia, they can do pain assessments using the technology. And for children, for mums and dads, this will be a super tool. They'll have the thermometer at home, the PainChek pain assessment, and they can manage pain and fever at any one time.
So you're innovating, you're disrupting that market. Why work with InterSystems?
Sorry?
Why work with InterSystems?
You're
succeeding.
Well, the big thing for InterSystems is that we want to also get into the hospital market. The hospital market is a very large market opportunity for us. We integrated our technology into aged care with the local aged care providers, but for the hospital market, you need a big player like InterSystems. So we've got the middleware all integrated now. We've got TrackCare, EMR all working. We've got the first 2 or 3 sites are working. In fact, tomorrow we're actually, Friday, we've got a big call with one of the UK clients, and we're looking to actually work with InterSystems and TrackCare to take the PainChek technology into the hospital market. But moreover than that, if I could just add, it gives us the opportunity with TrackCare to combine pain with the other vital signs, with blood pressure, temperature, respiratory rate, and heart rate. And by combining those together, we think we can develop a predictive tool to identify a deteriorating patient faster before they do deteriorate.
That's a lovely story. I'd like to come back to that. Let's keep that for a little bit later. Let's move on to Murray. Murray, what makes InterSystems a good partner for you in what you're trying to do?
So InterSystems are a great partner for two reasons. So one is the integration with the hospital systems. So we're now, one of our principles is always the information we gather from the patient, the structured history that we gather from the patient, we want to put in front of the right clinician's eyeballs. And where are they looking? They're looking in the hospital system or in the primary care system. So actually that information has to be surfaced within a system they're already looking at. They don't want to be logging into something else. So InterSystems are a partner to help us, and we're connected into Iris, and actually then, InterSystems are very well penetrated, particularly in the UK, where we're starting, actually get us into a lot of the hospitals. So that's the kind of interoperability reason. But there's the other reason is actually to help start thinking about beyond the UK. So actually, you're a global business, and I would love to take, particularly what we're doing in the emergency department, into other countries.
So your innovation was triage at a point of the GP patient access. Now you're taking it to a hospital, and you're taking it to particular settings, aren't you? So emergency department, possibly other departments in there.
Yeah.
But what is that innovation? What have you done? You've stepped back, if you allow me to say, and you've looked at how that innovation can be applied in new places, in other ways.
Yeah.
So are there things that you're finding or things that you're looking to do that are different now that you're in or will be in a more of a whole health setting?
Yeah, I think what we're focused on is actually changing how that story is gathered from the patient. So when I was at medical school, all medical students around the world are taught to take a history from a patient sat physically in front of them. And then that just carries on forever. So when you're in any kind of doctor or other clinician's setting, you're generally sat in front of the patient taking the history. What we've done is we've broken that consultation apart, and we're doing the history taking bit with the patient not in front of you. So it's a kind of asynchronous consultation. And that's the bit that we've taken from primary care and now into hospitals. So in an emergency department, you've got a patient who's walked into your waiting room, but instead of actually sitting them down with a triage nurse, we present them with a whole bank of iPads. You have you match the number of iPads to the peak demand, so there's never a queue. And at the iPad, it'll ask you who you are. So it works out who you are as a patient, and then it'll ask you why you're there, and that's the key bit. It takes that story from you, but in the patient's time, not the clinician's time. But of course, from that information, we can then gather enough information to work out who's sick and who's not sick. So within 5 minutes of everyone arriving in the department, you know who they are and how sick they are. And certainly in the UK and beyond, that time to triage is a massive problem. So in some departments, it's like an hour and a half. And actually, as a clinician, you don't know who the sick people are in that queue. So it really helps with the clinical safety. So yes, we're taking that concept, which applies in every kind of health setting, primary care, pharmacy even, emergency room, outpatient specialist setting, and applying that same principle to each of those settings.
And how does InterSystems is helping you in that? How is it playing a role in that?
So it really is that kind of scaling into hospitals. So for us, we're in that bit.
So it's the interconnection.
It's the interconnection, yeah, it is. And beyond that...
Make sure I understood that.
And beyond that, probably the international as well.
International market. We'll come back to the what ifs of the future, as Dean Andrews said so beautifully. And Kenzie, so what led you to work with InterSystems?
Well, I met your team at TechCrunch Disrupt Startup Battlefield. So we were finalists this past October, and we were kind of mapping out our vision. So we sell to schools and school districts primarily right now because that's where we're using our technology to screen students, and we bundle that with a platform for families so they have access to educational content, behavior tracking, consent forms, all sorts of things to help them interact with the school and help the school sort of manage that process. And we've been trying to figure out, what is our approach to work with providers and payers. We know there's a lot of value. there's a lot of cost savings and time savings, but how do we penetrate that side of the market, especially since we have a marketplace model that involves so many different components of the ecosystem, and frankly, selling to schools is not the easiest, and we chose schools specifically because it's hard. There's a huge moat if you can tap the school market and do it in the timeline that we are doing it. And providers really felt that. So we started talking to a lot of clinicians who felt, hey, I'm seeing these kids in the emergency department who are suicidal, who are struggling with eating disorders, who are harming themselves, and our system is broken because I'm seeing them when they're in the ED. And I feel like I want to be able to reach kids earlier. I wish I had mobile school-based clinics or, mobile crisis vehicles in these areas. And we started to kind of put the pieces together and realize, well, we are building what will be the largest data set of pediatric mental and behavioral health screening data and social determinants of health data that could absolutely be used to build predictive behavioral health models, but also to give health systems access to heat maps and information of where the kids are that are struggling the most and where the opportunities are for early intervention when you catch kids at that sort of mild or moderate stage of, for example, anxiety or depression. And so we are now in the KidsX Pediatric Healthcare Accelerator, and we're working to close our first health system partnerships there, and we've built out our payer model, and so we're looking at coverage, and we're just kind of figuring out the right route for expansion. But needless to say, we can do none of that without a pathway to EHR integration, and that's where InterSystems and ultimately the Iris Health platform come into play for us.
So data-driven, scalability, interoperability, and I would say the intuitiveness, the need to easy access, the intuitivity, can't say the word, but systems have to be easy to use, don't they? And we're now living in a world of consumers, both for the technical people, for the caregivers, and for the patients. So I love that idea, and I think that when you get into the journey, though, what are the unexpected opportunities you're seeing? Are you seeing your early stage, and I'm going to get on to Maro and Philip in a minute, but do you already have an idea of where you started? You were in one place, and now you see, and maybe it's that volume of data, that insights.
So what's been so exciting is getting our early data back and realizing things that people don't know because the data hasn't existed in the school setting. And so one of the coolest things, we just screened over the course of 2 days in a smaller charter school in Northern California, 122 middle school students. And we had 19 flags for potential suicidality. We had, I think it was 9 kids total for severe anxiety or depression. There were some comorbidities there. And then we had a cohort of about 35 kids in the moderate category for those, and then you had mild and non-minimal. And you're dealing with these overburdened school counselors who maybe are a one-person team, right? And so our software helps sort of, triage the referral process and spread out the tiered interventions. But what was so cool is we realized not all of these kids actually need to be immediately referred out. The counselors are doing such a good job of looping in the family members to assess, is this child really suicidal? Or, we're assessing over a 2-week period. Kids have bad days and they respond differently based on different factors.
Yeah.
And so diving deep and going, maybe do I need to take these 8 kids and instead of sending them to a therapist or putting them on a wait list, which is a reality in a lot of places, although we partner with a lot of virtual care partners to avoid that. What if we created a small group with these 8 students who have moderate anxiety and we teach them coping skills so I can spread out my time as one counselor now with 8 students instead of doing, in some states there's 5 sessions a counselor will do per student that's struggling. And so we're trying to optimize and really democratize access to our existing resources. And it was just really sort of unexpected to see that play out in ways we hadn't even imagined and give us all of these new ideas for how the platform can support those tiers.
That's amazing. And that data helps with driving and supporting those passionate people you said, the early adopters. It really gives them belief and it helps drive that change. But I love the idea that you're talking about the predictive and the early intervention for those that may fall through the gaps. So thank you. You're doing a great service, I think, for America, but also I think a change bringing, I hope, to other countries as well. Murray, so you talked about now being in a hospital setting and other departments. How's that changed your worldview? How will your business pivot? And indeed, and here's I think an important point for businesses overall, but particularly startups, how do you remain focused on your original passion? What's a pivot and what's a distraction?
Yeah, absolutely right. You've got to really be laser focused on what you want to do. So actually, and what we are trying to do is just do the digital triage bit at the front of the journey. And I'm then very happy to work with other partners who do the other bits. So actually, I'm no good at interoperability with systems, so work with InterSystems to do that. I think the bit that we haven't pivoted, but the thing we've realized, so back to your kind of point about what have you realized along this journey that unexpected has come out, is the data. So we're sitting on a lot of structured data.
Data again, okay.
It's data again. And actually, the data unlocks really the future for us because we're capturing a data set that didn't exist before. So you used to go in and see a clinician, they'd ask you some questions, and then they'd write down their interpretation of that data in the notes. We're taking a structured history now on over 1 million patients a month. We ask them 50 to 70 questions each time. That's a huge amount of structured data. And if you can match that to what the clinician then does, you can then start to apply some automation to that. So again, bringing that user on that journey over time, but we can start to say, you sent those last 5 hay fever cases to the pharmacy, do you want us to do that for you next time? So it starts to bring in that automation and routing to the right clinician automatically. And the data is what unlocks the power of that. And actually, even though today I'm selling into 3 doors of healthcare, primary care, kind of emergency and specialist, ultimately what you want is just one digital door. And actually as a patient, when you answer some questions about what's wrong with you, the system can determine which is the best place to put you.
Yes,
So
and of course patients don't fit neatly into one box. They might have multiple conditions, chronic conditions, they might have mental health issues, they might have family background issues, all of which we need to treat people as people.
Yeah.
And giving them the ability to tell their story consistently, easily, is something you're doing. And I thank you very much for that. Philip, unexpected.
Yeah. Well, I think the really exciting part, and which has come much faster than we thought, is the fact that we get in some really, through the data again, through the data analysis, and we store every single pain assessment on our back end. We now get really good outcomes data, and especially in the UK, we're seeing that in long-term care, we're being able to reduce the use of things like antipsychotic medication by more than 30% in key aged care facilities. And that's because people with dementia, if they get aggressive, people think that's caused by the dementia, when often it's an underlying cause, such as pain. If you identify the pain and you treat the pain, you change the behavior. So we've seen reduction in use in antipsychotics, we've seen a reduction in use in benzodiazepines, which is actually a tranquilizer, and we've also seen reduction in falls, because if you're in pain and you're in a long-term facility or in a hospital, you're more likely to fall. So this is actually driving the utility of the product as people see the benefit of assessing pain better. And in hospitals, I mean, this is a really exciting thing with TrackCare and with Iris, is that if you look at hospital, people living with dementia, if their pain isn't managed properly and they're in a hospital, they will typically stay in there 18 days longer than the average patient. They are 3 times more likely to have a delirium, and they're receiving more than 50% of more antipsychotic medication than other patients. So working in hospitals with TrackCare and Iris, we want to analyze that data, and we want to be able to provide those trends to reduce those situations, saving cost and improving care in the hospital setting.
Thank you. So we're coming right to the end of the session, I believe. That clock tells us we've got just under 2 minutes. So I know you two have met here, maybe for the first time. And that's, I think, true for many of us here. And you've already had an innovation. So tell us what you two are going to do. Murray, have you?
Yeah, no, sure. I mean, so one of the things I referred to earlier was us working with partners, because actually I want to do the bit that we do well, which is gather the story. But one of the bits we want to build in is diagnostics. So while you're standing at the iPad and we take the history from you, wouldn't it be great if actually we could also capture some diagnostics? And so actually a really great thing that we could do is plug in PainChek and actually get a visual pain score that's kind of validated and consistent. So we're meeting up, in next week, and that all came out of this week. So
very quickly, I'm struggling against time. Kenzie, where do you see yourself and Maro in 5 years' time?
Applied predictive behavioral health modeling.
Applied predictive behavioral monitoring. I think that sounds fantastic. Murray, 5 years' time.
I'd like every health journey to start with an eConsult. So,
right.
And I don't just mean in the UK.
Start the journey well for the patient. Philip, 5 years' time.
Fully embedded in the United States and Japan and other markets in the world, so become a real global product, and most importantly, to make pain visible for all people.
Right, well, I think that's wonderful technology, wonderful insights. I really thank you for that. But what's amazing, the technology is good, but what's amazing is the quality of lives are being changed by what you do, and I thank you for that. I thank the audience for your time and attention. A round of applause for our panelists, please. Thank you.